Hello, everyone, and welcome to our 11th question and answer session with Dr. Rick Moss. For those of you who are joining us for the first time, Dr. Moss is a preeminent CF clinician and researcher at Stanford, the former head of the CF Center at Stanford, well known in the field, and we are so grateful to him for sharing his time and his expertise with us today. And I have some things to remind you. The date today is Wednesday, June 24th. It's always important to mark the date because things change so quickly with COVID-19. And so we need to make sure that you, if you're watching this later, you realize this information may already be outdated. And of course, as always, this is not to be meant to make any decisions about your own healthcare. Please, if you're thinking about any changes in your CF care, consult with your team in advance. It's interesting, this is the first time we've done this session in 4 weeks. There are many questions that have come in from the community. Thank you all for doing so. But it really made me curious just about how quickly things are evolving. And I went back through some of our old recordings, Dr. Moss, and realized that the first, like April 1st, we did a session. I think it was our third recording. And at that time, there were about 4,000 deaths in the United States. And we were horrified because literally 2 weeks before when we had our town hall, there were 4,000 cases in the US. So in a period of 2 weeks, the amount of deaths had equaled the amount of cases. And of course, those numbers now, we realize just how small they were and what was to come. So with that, I'm going to turn this over to Dr. Moss, and I welcome you and thank you for returning.
Good to be back, Siri. I appreciated the vacation.
Well, I realize there are many questions, and as our CF community always does, we ask hard questions.
That's for sure.
So as always, we will start with, if you could update us as of today, the current numbers of cases and deaths, both in the US and worldwide.
It's interesting, what you just said now reminded me of the fact that the United States and South Korea reported their first case of COVID death on the same day. I think it was something like January 23rd or something close to that. And South Korea currently has something like 400 deaths. Today in the United States, it's approaching 125,000. Now, we're a bigger country than South Korea, and there are big cultural differences, but they're not a small country. There are tens of millions of people in that country. That tells you something a little bit about the responses of the two nations to this one virus. But in the world today, we have about 9.5 million cases, somewhat shy of that, 481,000 deaths. And as of today, the latest figure was about 2.4 million, over 2.4 million cases in the United States with that 123,000 deaths. And the number of cases yesterday was the third highest since the pandemic began. So this is not a second wave. This is as Dr. Fauci has said recently, this is a continuation of the first wave that we're having. Whereas other places like Europe have actually brought those deaths down and cases down, we reached a plateau and then never left that plateau, basically.
And what can you share with us about current number of cases among people with cystic fibrosis here in the US and abroad?
Right, so the CF Foundation has been sending out weekly reports to Care Network, which have not been very detailed, but do contain some numbers. So we're now up to 45 reported cases to the CFF from their network. It is of note that they've done they reported over 1,000 patients being tested, almost 1,100. So the positive test rate is about 4%. Of those 45 cases, 12 are pediatric cases below the age of 18, and 18 of those patients have been hospitalized, but only 3 of those are pediatric. And 12 of them have had what they characterize as advanced disease, which I assume means low baseline FEV1, although I'm not sure, and only 1 reported death in that group. And then 5 transplant cases with 1 death in that group, so only 2 deaths in the US. There's a lot more granularity in some of the information being reported from Europe through the European CF Society. By the way, that CFF report was as of June 18th, so a little under a week ago. And in the last European update, which was actually today, they're up to 94 cases, of which they have data on 85. And of those, 42 have been hospitalized, 6 ICU cases, only 1 patient on a ventilator and 1 ECMO case, and 3 deaths. As I mentioned, they have more granularity of their data. Most of those CF patients in Europe reported are between the ages of 18 and 50, which reflects the demographics of both CF population as well as the general population, that is fewer children and adolescents. And most of them have well-preserved lung function, FEV1 greater than 70% predicted. Only 14 of the 85 reports with information are in the severe category with FEV1 below 40. Most common symptom being fever and also lung disease. 16 of their cases needed supplemental oxygen at some time. Their test positive rate in the CF population is also 3%. So both in Europe and the US, that relatively low percent positive test to proven case ratio says that CF patients are by and large doing their physical distancing and other measures very well and remaining at very low risk, which I think reflects well on the community, very well.
What do we know at this point about the spread of the virus by those that are asymptomatic?
There was a bit of confusion about that recently because the World Health Organization had one news conference where they kind of downplayed it and said it was very rare. And then they walked that back the next day and said, we don't mean to say it doesn't happen. It does happen. But it is true that asymptomatic cases, which do exist, and in some reports, may be up to 13% of the total and have to be distinguished from people that are tested when they're pre-symptomatic, that is, they go on to develop some symptoms, versus those people that have never developed any symptoms. So if you put those 2 categories together, you're going up towards, in some reports, again, 40% or so of the total of very mildly affected people. And there was a very recent paper that was just published which looked in some depth at the people that were asymptomatic and showed that they shed virus for longer than those people that became symptomatic, on average about 19 days versus more like 2 weeks for those that are symptomatic. So actually longer shedding, lower immune response, less antibodies. And very disturbingly, they didn't do CAT scans on all these people, but this is a report from China. They did do them in a substantial number, and about 1/3 of them had pneumonia on their CAT scans, even though they were without symptoms. So lung damage is being caused, at least temporarily and possibly long-term, without symptoms. A very disturbing finding. So there's lots about this virus. We're still learning how protean its manifestations are and how variable the individual response might be in terms of symptoms, in terms of the immune system, in terms of how long the virus stays in the body. So there's still a lot to learn about this, but the short answer is that asymptomatic people can spread the disease, and again, probably much less so than people with symptoms. The most infectious time is after the appearance of symptoms for the first 4 or 5 days.
Now, with those studies in China, were these typically younger people, or was there a breakdown of age?
There was a breakdown of age. They did tend to be younger, and that is generally part of the picture, that the fraction of symptomatic people goes up dramatically as you age, especially once you get above the age of 50 or so. But with more testing, we're also learning that obviously more and more people between the ages of, let's say, 18 and 50 have been infected. They tend to be mildly or infected or without symptoms or very mild symptoms. But as noted, they can have lung damage even without feeling sick.
But it's such a terrible mix, isn't it? The youngest group are most likely to be asymptomatic. That's also the group that's the hardest to convince about physical distancing. And
Part of the paradox, especially in our country where there's much more resistance to doing things one does not feel like doing.
We are culturally ill-equipped for this.
American individualism in action, yes.
Yes. Can you share any current information on the development of a vaccine for COVID-19? And what are any known potential risks we should consider before we get one once they're available?
Yeah, really two questions there. Just the first, just on the general theme of development, there are at least 8 different COVID vaccines that are now in the clinic in early and even some in mid-phase trials. So that's going very well in terms of getting things moving. What we don't know at all yet is really how safe or effective any of these are, and that's the second part of your question. So that's going to have to wait for the phase 2 and especially the phase 3 trials. Because one thing we don't want to find out is relatively rare but very serious adverse reactions. That can only be learned once you vaccinate a large number of people. And usually these phase 3 trials of vaccines involve tens of thousands of people. They're large, large trials. So that is the current status of things. And there are phase 2 trials now in the United States and several other countries around the world, including China, with several countries in the EU, Germany, and the UK also. So it's quite a broad effort.
Is there any merit to the study regarding using an existing and unrelated to COVID-19 live vaccine as a means to activate the immune system to protect against severe COVID-19 complications?
Yeah, that's a really good question. Somebody's been doing their homework out there. This is something called trained immunity. And it's a concept that's relatively recent, recently supported by studies, scientific studies that show when you give certain live attenuated vaccines, and there are a number of those, to people, the immune system can be boosted to respond to other things. And those things include the oral polio vaccine, the measles, mumps, and rubella vaccine, and the TB vaccine called BCG. Those are the 3 best known live attenuated vaccines. And 2 of those are viral and 1 of them is bacterial. So there are now trials actually started with BCG and people talking about starting polio vaccine and measles, mumps, rubella vaccines to see if they actually improve the response to coronavirus. And it is entirely possible based on the immunologic understanding of how this might work. Basically, you're stimulating the early part of the immune system to upregulate its responsiveness. So when it sees something, even though it's not related, it will have a better response. And we know that one of the reasons people get COVID is that their innate or early immune response tends to be stymied by the virus. So it's possible that these so-called trained immunity vaccines may be helpful. And hopefully we'll know in a few months whether or not that's the case.
And with these live attenuated vaccines, is this something that people post-transplant would be able to utilize?
Not so much, because they're immunosuppressed. They have to be on immunosuppressive drugs. So those folks usually do not get live attenuated vaccines once they've had their transplant medication started.
What is your opinion on recent preliminary studies that show a person's blood type could determine how adversely impacted they are by COVID-19?
Yeah, this comes out of a very large study, which is applied now to many diseases, looking at genes. And we now have the ability, technically, to look at the entire genome and scan through the genome of many people at thousands of genes to look at the level of expression of various, particularly when there's so-called polymorphisms or differences in the population in those genes. So what came out of the first large so-called GWAS study of people with COVID was that one of the areas that popped up was the blood group gene area. And they saw an association between a higher prevalence of type A blood type with disease and a lower prevalence of type O blood type without the disease. What that means, though, is unclear. So it's a very preliminary result. And certainly we don't understand the mechanism that would link changes or the difference in blood type between people to susceptibility. But it doesn't, it's not absurd, because we do know that this is a disease that affects the blood. And there might be the way the red cells, which express these proteins, these blood types, interact with the blood vessel lining, that could be involved in the pathogenesis of the inflammation we see in the blood vessels in many patients. So that's something that needs to be followed up, but at this point, I would be cautious about it, over-interpreting that. There was one other large area in the human genome, which was found to be a hotspot, and that's linked to some immune response genes, which makes a lot of sense also with COVID.
Has there ever been another disease that has had this association to blood type?
Yeah, in fact, blood type has been linked to certain coagulation propensities. So it could pan out, and it's something that has a lot of interest now. People are looking at that, but I think it's premature to draw any conclusions.
Is there any new information on the longevity of COVID-19 antibodies?
It tends to, that's done by measuring the shed of viral nucleic acid, the gene part of the virus. So you can detect that pretty easily with those nasal swabs or other tests that use the PCR technique, the way you detect these nucleic acids, which are very specific. And that tends to be generally about 3 weeks in general, but there are outliers. So some people clear it more easily, and some it lingers on. As I mentioned just a while ago, people that are asymptomatic actually shed longer, according to the latest research. So what we don't know is how infective those detection systems translate. So we don't know if that's dead viral genome material or actually infective viral particles that are being picked up by the test. And to do that, you'd have to take that back to the lab and look at infectivity tests, which are much more complicated. So that's still an unanswered question.
What are the current and most effective treatments for COVID-19? I heard about a steroid, dexamethasone. Am I pronouncing that correctly? That is helpful.
Yeah, that was a very, very important study it was done in England, in the UK, and very large study, very well done. What we have now is just the press release. So it's not been peer reviewed, it has not been published. So that's led some physicians to be a little bit skeptical, but the numbers were so large and the statistical difference was so enormous that most people are sure that really does represent a real effect. So and this is for people that are sick, very sick. So what was observed was that dexamethasone, when given to people on a ventilator, reduced their risk of death by 30%. And if they were just receiving oxygen, not necessarily on a ventilator, but just getting supplemental oxygen, it reduced their risk by 20%. And statistically, those are very significant numbers and meaningful. If you can get almost a third of people off the ventilator more by using dexamethasone, that's really very important. So that has already, I think, changed practice, and most ICUs are using dexamethasone now based on that report, although we're eagerly awaiting the actual paper to go through it with a fine-tooth comb. The other drug, of course, is remdesivir, which we've talked about previously, which really also has shown to be of effect in hospitalized patients who are also very sick. What we don't have yet are any drugs that really work on the front end that either prevent the disease or prevent the progression to the more severe hospitalized cases. That was where the whole chloroquine story, hydroxychloroquine story, was, eventually found its way and, died a ugly death. So we really don't have anything in the early phase of the disease, and that would be a huge thing to be able to do that. So those studies have to still be done, and there are many, many drug studies that are ongoing. So we're starting to get these results come in now.
Right before we logged in, I saw a press release that Gilead is starting to test an aerosolized, nebulized version of
which would address exactly that problem. In other words, remdesivir is now only intravenous, so you have to already be in the hospital to get the drug, and the supply. You know, there was a bit of a problem getting the drug out to where people wanted it, and they're having trouble producing enough. If they can get an inhaled version, which people with CF know all about, we can use it as an outpatient early basis. So it might be actually more effective when used earlier. So that's a very exciting development.
That's great. Okay, we'll circle back to this, I'm sure many times during our talk, but why are some countries that had seemingly eradicated this virus now reporting second waves of COVID-19 infections? Is there anything we can learn from these circumstances?
Yeah, I think this is related to the fact that we live in an interdependent, interconnected world these days. But we also live in national units. And a lot of the problems with reappearance has to do with people coming into an area from outside and bringing the virus with them. So that gets us to the ways that one deals with that, and that is really through testing and contact tracing. And I mentioned before how successful South Korea has been in its effort. They have a massive capability to do just that, testing and contact tracing. I just read, I think it was this morning, that China reported it has done 90 million tests, which is 3 times the total number that's been done in the United States, which gives you another sort of window into the magnitude of what's required to really do surveillance. And exactly, they've had an outbreak in Beijing recently, which has led to a near lockdown of the huge city, 20 million people, just in the last week or so. And they still haven't really at least told the world what they think about how that happened. So whether it came through one of these animal markets, or some other factor, we don't know. But the key to staying on top of these is to be able to do large-scale testing, to detect these outbreaks early, and then have the capability for contact tracing to end them. So those are the key factors, both of which are still deficient in the United States, broadly speaking.
And the next question submitted by someone, is contact tracing being used effectively in the US? How can we take part in this practice?
Right. So remember that in the United States, we don't have a national plan. What we have, we've some national guidance from the CDC and the NIH. We have some national misguidance from the administration. Put it all together and we have a lot of confusion. And we have basically a policy of allowing each state to go its own way. And then within each state, we have variable responses within counties that deal with their governors and their state leadership. So the question of contact tracing in the United States is really very regional also. Some areas are doing a good job. Dr. Redfield, who's the head of the CDC, testified, I think it was yesterday, in the House, and said that the estimate is a need for about 100,000 contact tracers. He said right now we have 28,000, so we have less than a third of what we need to have an adequate system, nationally speaking. So that gives you a pretty good idea of where we're at.
And this is somewhat of an aside, but with the contact tracing, they find all the contacts, anybody who might have been exposed. But at that point, there's no mandate to be tested, correct? It's an optional.
Yes, although again, this relates to the different countries and societies that we're talking about. For example, in China, the way they handled the virus in Wuhan was to take people and put them in isolation by mandate. They didn't have a choice. They were directed to go to a facility where they would have to stay for the 2 weeks in quarantine. They were not given any options. So that's a pretty draconian approach. It worked extremely well in Wuhan and actually did shut down the transmission of the coronavirus in China. So this is a successful approach that is very unlikely, I would say probably impossible to implement in the United States. Here, it's a lot of cajoling and arguing, and it bumps up against misinformation and cultural problems and political differences. So we are never going to have a containment policy that works as well as some other countries.
Right, and what triggered that for me was the article I think we were talking about last week with the two hairdressers in a Great Clips in the state of Missouri who cut the hair of like 140 people over 6 days, but they were wearing masks. And so of the people that were tested, whose hair they cut, nobody tested positive. But they also noted that a lot of people declined to be tested because they thought, if I do test positive, I cannot go to work, hence I cannot pay my rent. So it just was a reminder of how hard this will be because there are economic reasons for people to avoid testing.
Right, and again, that brings us back to differences in the economies of different countries. So, for example, in most of the EU, the social safety net is much stronger, and it's a lot easier for people to go through that quarantine period if they are test positive. Whereas here in the States, a lot of our so-called not first responders, but essential workers are going to go back to work because they have no choice. Else they're going to be out of a job and they have to feed their families. So though that plays into the overall situation also. It seems that the US represents almost a perfect storm of disabilities with regard to responding to a pandemic. And that's what we've learned.
A hard lesson.
A really hard lesson. And people are sick and tired of it. And unfortunately, the virus is not cooperating by going away.
Right. In fact, I'm going to skip back to this next question because I kind of want to stay on that, which the next question was, with COVID-19 cases on the rise, why are we seeing more phases of reopening continuing to unfold? It is confusing to see businesses and youth sports opening up and communities at large behaving in unsafe ways during a pandemic. This more relaxed behavior seems to encourage the spread of the virus. Do the areas in the US with spikes of COVID-19 correlate with the differing states' policies and/or counties' policies on reopening?
Well, it's a broad question. I think in terms of a very general answer, there does seem to be a correlation between the stringency of the public health measures that were taken and the speed of reopening with the upticks that we've seen. So if you look at the states that are having the most problems right now, I can think of Arizona, Texas, Florida, Southern California. Those are all areas where there's a lot of resistance either at the county or state level to the kinds of public health measures that the epidemiologists and public health people have recommended. Yeah.
We spoke, several times through our past few weeks about the high numbers of COVID-19 among Latinos and African Americans. And now that the numbers are so huge, is this disparity carrying out in a broader scale?
It's a very real disparity, and there's a very real disproportion between the percentage of African Americans in the population and the proportion of people that develop the more severe COVID-19 disease, up to 4 times higher in African Americans than others. And we're seeing this also in areas where there's a high Latinx population also. Not quite as bad, but also very notable. Absolutely, and that's not going away. And that, of course, reflects a lot of different possible differences that include just built-in discriminatory practices in access to healthcare, insurance, employment, and the possibility of biological differences can't be excluded. There are some studies that suggest that there are perhaps differences in receptor levels in people, African Americans who have respiratory disease, but that's preliminary. I think the main factors are probably social.
Now I'm going to swing back to the R value. What does the R value mean for COVID-19? Is it a means to predict future cases, or is it a real number reflecting active spread of cases?
Yeah, this is a central concept in infectious disease epidemiology. And there are really two R values, which R stands for reproduction value, a reproduction number. There are two reproduction numbers that are used. The first is called R naught, which is a capital R and a little zero subscript. You'll see that a lot. And the R naught is the number on average, the average number of people who will be infected by one person that has the disease. So that difference between different infectious diseases, and most people have put that number for this virus at between 2 and 3, which means one infected person on average infects 2 to 3 others. A very recent report just came out which rethought that, and this is kind of worrisome. They came up with an R naught of 5.7 in their re-review of the literature and the available evidence, which would make it even more infectious than we thought, and one of the most infectious diseases. And we've always known this is a highly transmissible disease, but that would make it even more of a problem. Now, the caveat to the R naught is that is in a population that's completely susceptible to the disease. And that's where we started in January and February, right? Nobody had immunity. Now it's more complicated because a creeping upward proportion of the population has been infected. And so they're no longer susceptible, at least initially, we think. So that's a second R number, which is called the effective reproduction number, or RT. And why they changed from effective to T, I don't know, but it's called capital R, little t. And the RT number is always going to be lower because it takes away that portion of the population. And the R naught number is really, it's complicated. It's a result of how long you stay infectious when you get an infection, how much contact there is, what the contact rate is, and also the mode of transmission. Is it through droplets, or is it through aerosol? Is it through surfaces? Is it through what's called fecal-oral route, which certain diarrheal diseases, for example, are transmitted by? Is it a sexually transmitted disease? So all those things go into how the epidemiologists come up with that R naught. Bottom line, this is a pretty infectious disease, and we know that now. And that's why these events of staying inside with large numbers of people without masks is not just a prescription for disaster, but we've seen multiple cases of that. And we'll see more as we see more of these events take place.
My child's CF center is starting to schedule clinic visits.
Yep.
I'm extremely nervous about PFTs and worry that if someone with COVID-19 who's asymptomatic has his or her pulmonary function testing prior to our appointment, my child will be in a room where coronavirus particles may be suspended for a long time. What are best practices for CF centers?
This has been a topic of discussion, as you might imagine, of the providers, the hospitals, the clinics, and the doctors and others in the clinics who are doing this, respiratory therapists. And it's pretty complicated, so you do have to make sure that you avoid that problem. So each place will develop its own. There's no sort of policy that's come down from on high somewhere. Every institution and clinic has to figure out its own way. So we've reopened our clinic, and we're doing spirometry in the clinic, and also reopened the pulmonary function lab in the hospital, but have taken very stringent measures. We screen the patients. Obviously, all the staff are also screened. The staff has been tested. And the actual procedures themselves involve a period of time after each test, and we've set it at half an hour. Other places may have a different time, where nobody goes in that room and then it's decontaminated before the next test is done. So we think it's a safe method. And it's important for people with CF to have their PFTs checked. Another potential, this is interesting, possible partial solution to this, like telehealth, is to move these tests into the home. And nowadays, luckily, we have the technology to use home spirometers that are gotten pretty good. So one thing that people might consider is to do more home spirometry, which involves getting one, having it covered, paid for at least, and learning to use and making sure you're using a device that's been vetted. And I think, like telehealth, this is a change that's probably going to be enduring beyond the end of this pandemic. But for many people, they do need, obviously, to get tested at the healthcare facility. And so I would say, make sure you're in dialogue with your center, find out what their policy is, make sure you're comfortable with it. If you don't understand it, or you think that there's a piece of it that feels unsafe, ask the question and make sure you get a good answer before you allow yourself to go in and get tested in the clinic or in their PFT lab.
And I know every clinic is different, but if a patient said, I have a home spirometry tool, I would rather do that, would that be accepted by most CF centers, do you think?
Well, I think there would be a discussion about that. Make sure that both sides have confidence in how it's being done, and what that particular device's characteristics are. But in the US, the CF Foundation has sort of given its blessing to a couple of commercial devices that are available. And so I think that for many people, this would be a reasonable option for at least the routine PFTs.
Great. There's debate among scientists as to whether the virus is weakening and could die out without a vaccine. Is this true?
Nobody that I know of who is really conversant with the virology thinks that the virus is going to die out. The big question has been, will it be seasonal, like most flu viruses are? And so far, we've actually seen no real evidence of that. So it looks like it just is going on. It doesn't care whether it's 90 degrees out or 30 degrees out. There is a lot of tracking of the structure of the virus in terms of its genome. This is something that is being done around the world. And one strain has emerged as a dominant strain around the world, which initially was, in the first paper, said to be more transmissible. And then there was a lot of pushback on that. And more recently, that has been backed up by some further study. So it looks like the main genetic variant of the COVID-19 virus has actually increased its ability to be transmitted. And it does that by making more of the spike protein, which is the way it attaches to the cells on the body. So if anything, it's become more transmissible. There's no evidence that's become more virulent in terms of how dangerous each virus particle is, or less virulent. So most people don't feel that there's much change in the virulence, but the transmissibility may actually have gone up since this first appeared.
What do we know at this point regarding possible complications due to COVID-19, such as Kawasaki disease, inflammation, rashes, blood clotting, and stroke? And even that case, a woman who needed a lung transplant, right, who's not a CF patient. Do we know that all complications are in fact COVID-19 related? How do we link them?
Yeah, and this is a particular problem for that pediatric condition, which is an inflammatory syndrome that looks a lot like a disease we had known about for several decades called Kawasaki disease, which affects the blood vessels, especially in the heart. And so the relationship to the COVID virus has been a little bit difficult because this happens many weeks after the first onset of the disease, which is puzzling, right? But most of those cases do have evidence of antibodies or actual PCR positivity. So the consensus is that it is related. It's a downstream sequela or evolution of part of the inflammatory response. And a lot of these things that you described in that question are in that boat, where they're not early, they occur later, and they seem to represent more manifestation of inflammatory responses in various parts of the body than to the initial invasion that occurs in the lungs.
Has the age range indicating more severe symptoms changed to include younger generations?
Well, I think what's happened is as more testing has gone on, there's been an appreciation that young people are not immune to being infected. they are more resistant to being sick, but they're not more immune to being infected. And that gets back to our earlier question about asymptomatic or mildly symptomatic people. They can still spread the disease. So I think we've learned that that is a real problem, and that has resulted in a shift in the sort of age distribution of the disease as more testing has gone on. Remember that testing initially started in the most high-risk groups, healthcare workers, people in the hospital who are very sick, and only gradually over weeks and weeks have the capacity expanded so we can now test more and more young people, apparently healthy people, people that may not have been contacted, so-called community surveys of where the virus is. And that testing does show this, the fact that the virus doesn't so much care about the age of the person, it's the body's response that really determines whether it's a problem for that particular age group. So below the age of 18, very rare, only 2 or 3% of the COVID spectrum is in that pediatric category. The rest older, and of course, that big bump once you get above age 50 to 60, especially after 65.
Another person asks, is it true that COVID-19 doesn't live very long on surfaces as previously thought? Does this mean we can stop wiping down our groceries and mail?
Yeah, this is another area where there's been some semantic problems. So the CDC put out, they changed a statement on their webpage that deals with this area by saying that it's a rare event to get the disease from surfaces. And then they had to kind of walk that back a little bit by saying, we didn't mean to say that it doesn't happen. We just want to let you know that it's the likeliest way you're going to get infected is through droplets. But the droplets can, deposit on surfaces. And if you are exposed to that, you can get sick. And that has been documented in many cases, especially within a hospital where the dose is high. A lot of virus is around and in particular rooms, and that's where most of the transmission has occurred. So they're trying to say something a little subtle, which is, don't worry about it so much, but don't forget about it. We still want you to wash your hands. We still obviously want you to wear masks, and we still want you to stay 6 feet apart from anybody that has been exposed or has the virus. And those recommendations stand. But it's a relatively lower risk than droplet transmission in the air, where you're, let's say, in a room and people are yelling and screaming, and the virus is going out into the air, and you're not wearing a mask, and you breathe it right in.
It's like a horror movie. You can see the droplets just
like a zombie movie.
Oh, yes. But in answer for the person who asked that question, if it makes you feel better, keep wiping down the mail and groceries.
Yeah, I mean, there's been this presumption that if something's been in the mail, it's taken long enough so that there's no viable virus left. And the early studies looking at surfaces, they tested viral particles. They didn't really look at infectivity in a realistic way. So the question is not completely answered, but I think the risk is relatively low. And certainly, if you're getting a delivery, through Amazon or UPS, that's probably quite safe just to take in. Same goes for the Daily Mail, newspaper.
And of course, we're all using hand sanitizer all the time. And then we find out that some hand sanitizers on the market contain methanol that can cause seizures, vomiting, vision issues when it's absorbed through the skin. How do I know if my hand sanitizer has methanol in it?
Well, I looked at this question, and it turns out, as far as I could tell, that this is all from a company in Mexico. Unfortunately, according to the FDA, there are 9 different products that use this material from this company in Mexico. And I don't have a list of those. There is a website that you can go to at the FDA that will give you that list. But the simpler thing is simply to if you either use soap and water, which is the preferable way, as it has been from the beginning, or if you're going to use a hand sanitizer, just use one with at least 60% ethanol. Not methanol, but ethanol with an E, which does not have any toxic effects.
And if it's made, these are all made in Mexico. So if it says made in USA, would that be?
The product is made in Mexico, and then apparently it's, farmed out to different retailers who put it out under 9 different brand names. But again, I don't think, the likeliest thing from that would be irritation of the skin. You'd have to drink the stuff to really get poisoned. So, or have a huge dose, go through the skin. So I don't think it's a great risk, but it was enough of a problem that the FDA did put out this warning.
We'll make sure we put that on our website, that link, so people can see. It seems that taking people's temperatures is a common thing now in businesses, workplaces, restaurants, and airplanes, because so many people are asymptomatic and there are so many other symptoms of COVID-19 besides fever. Isn't this practice giving people a false sense of security?
Well, I think it provides some measure of protection, but it's clearly not adequate to pick up cases. We know from many now series that you don't always have fever. In fact, it's probably the most common symptom, but it's only in 60–70% of cases. There's a lot of people that get infected that don't develop a fever. So checking for fever is a useful first step, but it's not adequate to really ensure that that employee or that person going into the airport or what have you is not infected. So that question is perceptive, and it is not adequate to completely rule it out, but it does provide some level of screening. So many places do use that. I think the airports were one of the first places where that was implemented. I was actually in northern Italy in early March, and that's what they were doing at the airport, holding this little gun to your head, which was a little temperature gun. But that, that's not the highest level of sensitivity, right? Yeah.
So keep wearing masks, keep washing hands, keep physical distancing.
Right.
So moving on to masks, with the continued controversy over masks, what is your opinion on the use of cloth masks in public? Do they work and effectively help keep us safe? Which masks are best for family members living with someone with CF? Should someone with CF only use an N95 mask if out in public? That was a series of questions. The person with CF should only use an N95. What about family members?
Yeah, the N95 level is still, I think, something that should be reserved for healthcare workers. Because there's still some shortage issues in many places. Like I've heard now in Arizona, they can't get N95 masks to deal with the spike they're having, for example. So there still needs to be resolution of the supply problem for healthcare workers. For people with CF, probably the surgical masks, the polypropylene surgical masks that you can get over the internet, I think are generally available and do provide good protection, especially if both people in an interaction are wearing them, not just one person. The homemade cloth masks have been shown to be fairly effective if they're sort of double thickness, and best if they have a layer of that polypropylene in between the 2 layers of tight knit cotton. And so many people now have made masks, and they work very well. Again, if both people in an interaction are wearing them, it's been shown to cut down the risk by 75% or more, which is very substantial. So not totally foolproof, but if you're not a healthcare worker with heavy exposure, it's probably fine, especially if you maintain the distance. So I think just those common sense measures are enough.
If only everybody would utilize them.
The real truth on the other side are people doing anything. So you're right, and that's where the problem is.
Mm-hmm. Several hotels in vacation spots are open now. Is it safe to travel if we keep up with all our safety measures there as we would at home, meaning disinfecting all surfaces in the room, wearing masks, social distancing, etc.?
Yeah, that's a really good question. If you're planning to travel, I think it's really important to do your homework and see what the place or places you're going to, what their policies have, what they've adopted, what they're doing. How are they handling their staff, for example? Are they masked? Are they disinfecting their rooms? How often are they doing it? What kind of procedures are they using? So it will require a bit of spade work to tease out what's going on. If you're going to a rental unit, again, what are the people there doing with their rented home or apartment, whatever it might be? I think if you do the proper homework and follow those procedures, it probably is okay to do that. I wouldn't recommend it for someone who is immunosuppressed. So lung transplant recipients should probably stay home and not consider that kind of vacation. Get in your RV if you have one. But, nothing is risk-free in this world. So you really just have to look carefully at what has been done and what you can do and see what your comfort level is. How are you going to get to that place? Are you taking an airplane? That may be the riskiest part of the whole trip. So you need to check with the airline about what they're doing. And, they send out these wonderful PR letters about how great they're doing. And then you go and you find out that because they've knocked off 3 out of 4 of the flights, the plane is packed again. So there's a lot of ifs involved, and it really is a very individualized risk assessment.
I hear we never really flattened the first curve, and then I hear about the US having the most active cases in the world at this point. Is this a resurgence of infection or because there's more testing?
Oh boy, there's been some effort by people in the administration to say this is all because of testing, and all the experts and epidemiologists are unanimous in their opinion that it's not due to testing. Testing has been helpful. One way to look at that is to see the proportion of positive tests there are. So if you look at that, in places where the disease is well controlled, that number is going to be below 5% if you're doing adequate testing. If you're seeing spikes of proportions of positive tests above that, the disease is out of control in that area. It's as simple as that. If you look at the curve of cases in the United States and superimpose that on the curve from the entire European Union, you see 2 very different curves. In the European Union, it looks like Mount Everest. You got a slope up, you get a peak, and then you get a slope down. And that's where they are now. If you look at the United States, there's a 2-week lag because things got started there and then came over here. But that same upward curve is at the same slope. The peak is actually a little higher in the United States, even though Europe has more people. The European Union has about 450 million people. We have 330 million people, but our peak got higher. And our peak never came down. If you look at it, it plateaued, and we're still on that plateau, and the plateau actually is starting to go up. So very different looking curves that tell you that basically this problem has been controlled largely in Europe and uncontrolled largely in the United States. That's the story.
And no surprise that they want to ban any travel from the United States to Europe.
They haven't decided yet, but I would not be at all surprised if they ban Americans from going to Europe. Yes.
Our last question of the day, our CF Center is not interested in antibody testing. We believe our child with CF has possibly had COVID-19 and wondered if we should be on the lookout for any complications that could unfold in the future. Is there any reason to know if someone with CF has had COVID-19 and therefore need to test for antibodies?
That's a good question. I would say that if someone has, how would you think that you've had COVID? You look at symptoms you've had, and are they consistent with COVID symptoms? Fever, pulmonary problems, GI problems like diarrhea. There's a whole host of different, loss of sense of smell and taste, a number of other things. If a person with CF has had that, they should be tested. And the antibody test, again, we talked about this in the past, the problem with the fact that we have the Wild West of antibody tests. Nowadays, that's changing, and the better tests have kind of risen to the fore. So in particular, there are several very, very good tests available. And I would say the answer to the question is yes, you should know, because we don't know about sequelae of COVID, and it's becoming clearer that there's a lot of downstream complications, some of which may be chronic, that we need to know about. So I would say it is important to know if you've had the disease. If you suspect it, you should be able to get the test. I'm not sure exactly what the hang-up at that particular place is. The questioner says that their center doesn't want to do antibody tests. I'm not sure, why they're saying that. It may depend on what test is available. It may depend on what kind of coverage there is. I just don't know. But just in general, I think it is, knowledge is power. It's important to know if you've had the disease, because you may have some consequences from that go beyond that 2 to 3 week period. There are people who are suffering now what appears to be permanent chronic lung disease sequela from having the disease. So I would say it is important to know that.
Knowledge is power. Science will get us through this. Adherence to public health models, our only chance. Well, Dr. Moss, I am so grateful to you. This was a lot of questions. They've been building up. I thank everybody who submitted the questions, and hopefully we can entice you back to answer more at a future date. For those of you who are watching, I do want to remind you to go to cfri.org. We have many, many programs, some of them COVID-19 related, all of them programs for our KEEP community. One of them is our upcoming virtual conference, and we're really fortunate that Dr. Moss is one of our presenters on COVID-19 and cystic fibrosis. So Dr. Moss, thank you once again for sharing your time and your incredible expertise.
Thanks, it's been my pleasure. Good to see you again, Siri.